So today I'll be talking on nystagmus. So the first question is, why do we need a steady vision? So if we, one of the probability is that you might be not be having a stable vision, might be having a very shaky vision. So the vision which we see is not just the function of the eyes; it's also a coordination between the eye, the inner ear, and the brain to make sure that we have a stable vision. And if there is any incoordination with that, then one of the signs which you observe is nystagmus. So I'll be covering these mainly an introduction about it, about the review of eye movement systems, because it is a defect of the eye movement system which causes nystagmus, the clinical profile of patients which come to us, then how to differentiate peripheral nystagmus from a central nystagmus, then a brief talk about positional vertigo, and then nystagmus in early life, congenital nystagmus, and then acquired nystagmus, I'll talk about the localizing forms. And then how do you differentiate nystagmus from saccadic oscillations? So nystagmus is a Greek word which means nod off to sleep. So most of the time after lectures, you just nod off, and then suddenly you have a jerk. So that nodding off is a slow phase, and the jerk you have is a fast phase. There's a rhythmic, repetitive oscillations in the eyes. So it can be physiological, that is response to environmental stimuli or rotation of the body, or it can be pathological because of CNS disease, vestibular disease, or visual loss. So when you talk about nystagmus, you talk about symmetry. How's the direction of the nystagmus? Is it like is it conjugate in the same direction, or is it different directions, or is it like dissociated in which one amplitude of one eye is more than the other, or is just involvement of one eye, that is a monocular? Now, when you talk about nystagmus, you talk about the direction of nystagmus. So the direction is defined by the fast phase. So in a jerky nystagmus, it can be either right beating or left beating in a horizontal nystagmus, or it could be up beating or down beating in a vertical nystagmus, or it could be a torsional, rotatory type of nystagmus. It could be clockwise or anti-clockwise, or it could be a combination of all, like a circle or elliptical. So now this comes to the waveforms. Okay. Now in this video, I want to you have to tell me what's the slow phase and where is the direction of the fast phase. So this is a jerky nystagmus. So jerky nystagmus is a type which has a slow phase and a fast phase. So initially you'll have a slow phase which will beat in one direction, and then you have the fast phase which in another direction. So which is the direction of the slow phase? Yeah, it's actually medial. It is beating to the right side, and then the slow phase which is moving to the left side. So the slow phase is to the right, and the left is a fast beating phase. So slow phase towards the right, and the fast phase hitting to the left. In pendular nystagmus, you don't have the jerk. It's only the slow phase with equal velocity. So there's no fast phase in pendular nystagmus. So the pathophysiology is nystagmus is mainly the defect of the slow eye movement system. So the slow eye movement system is it's comprised of the visual fixation, the smooth pursuits, the vestibular system, optokinetic system, and the neural integrator. Most of the nystagmus occurs because of defect in either the visual fixation, the vestibular system, or the neural integrator. So as a result, what happens is your eyes will slowly drift to one side, and then you have the correction which is occurring, which is a fast phase. So why do we have eye movements? The eye movements to make sure that we have vision which is focused into the fovea. So if the vision does not get focused in the fovea, you get a lot of decrement in the vision. So the slow eye movement system is to maintain a steady fixation and also to follow moving objects. So the systems that hold eyes steady is visual fixation, vestibular system, optokinetic system, and the neural integrator. So visual fixation is you look at an object, it goes to retina, it goes to the optic nerve, optic chiasm, lateral geniculate body, and then it integrates what kind of vision are we seeing to the occipital lobe. Now it becomes tricky when the head starts moving. Now the head is moving, you need to fixate that vision into the fovea. So for that, we need to recruit the vestibular system. So this is the vestibulo-ocular reflex. So when this gets stimulated, if there is rotation, if the head rotates, you have the semicircular canal which is activated, and for linear acceleration, you have the ocular reflex get activated. So if the semicircular canal is activated, what happens is when you rotate your head to one side, your eyes move to the opposite side. So this makes sure that the vision comes to the fovea. I'll talk about how that is in the subsequent slides. The optokinetic system is mainly for sustain when there's a sustained motion of the visual field. When this occurs, the optokinetic system gets activated. It's like following a moving train. So when you have a slow pursuit which occurs following a train, and then after that, what happens is you have a different waveform. That is where you change to a next. You start fixing to the next target. That is the next saccade. So that is a physiological, is to make sure that it's like there's a diminishing labyrinthine signal. To take over that, you have the optokinetic system. It's a physiological system. The neural integrator is mainly to maintain the eccentric gaze. So you look to the right side, you have to make sure that the eye is at the right side. To make sure this is there, you have the neural integrator. So these are brainstem structures. You have neural integrator and horizon in one for the horizontal saccades and pursuits, and one for the vertical pursuits. So for the horizontal, you have the nucleus prepositus hypoglossae. And for the vertical, you have interstitial nucleus or Cajal. Cerebellum is also required to maintain the eccentric gaze. So when there's a moving target, the system which is required is smooth pursuit and vergence. So what is smooth pursuit? Is basically you're following a target. So target is like, let's say there's a person of interest for you. You start looking at the person, you keep following that person. So that is the pursuit. So how do you keep following? So you need visual system. So you see, first thing is that it is always ipsilateral. It's a cortical stimulation, which is ipsilateral. So ipsilateral cortical activity is taking place. So if I want to look to the right side, my right side cortical activity is there. Then it from the visual pathway, it goes to the lateral genicular body to a striate cortex. From there, it goes to the ipsilateral medial temporal lobe. From the middle temporal lobe, along with the frontal eye fields, the parietal lobe, the parietal eye fields. From there, it goes to the brainstem. The brainstem is the same as dorsolateral pontine nucleus. From the dorsolateral pontine nucleus, you have double decussation taking place in the cerebellum and in the medial vestibular nucleus. And this is basically to make sure that you have the calibration taking place of how much of eye movements to take place. And then further after that, you have the vestibular nucleus and the sixth nerve nucleus, nucleus and the sixth nerve, to make sure you have the movement to the eye, to the right side. They also communicates with the left medial rectus so that the eye moves conjugately to that direction. So in the end, what you get is a very smooth eye movements. There is no blockage in the eye movements. So very smooth movement which follows the direction. And it is ipsilateral control. The convergence and divergence are mainly disconjugate movements. So I spoke about convergence movements, which are like conjugate movements in the same direction. These are disconjugate movements in different directions, in opposite directions, either to focus onto an object like convergence at the level of midbrain, or following or looking at a distant object like divergence in the level of pons. Now, saccadic system. The saccadic system is mainly to look at a different target. So suddenly somebody calls me, say hi. So suddenly I have to change my gaze from looking at you to look into the other person. The sudden change in that gaze is a saccadic system. Now, contrary to the pursuit, which is ipsilateral, this is contralateral. So the contralateral higher cortical activity is getting activated. So from there, it is the contralateral. Like if I'm looking to the right side, my left frontal eye field gets activated, and the frontal eye fields, along with the parietal, along with will go and along through the basic ganglia and the superior colliculus, it'll go to the brainstem. The brainstem structures is the PPRF, that is the burst neurons, and that will cause activation of the sixth nucleus and the sixth nerve to look to that opposite side, along with the communicates through the MLF to the third nerve to make sure that my look at the opposite side. And important structure here is integrators are mainly to maintain that gaze. And also you have the omnipos neurons. So the function of the omnipos neuron is to make sure that you don't have any unwanted PPRF activity or unwanted burst activity. So if there's a problem with that, what happens is you will have unwanted saccades. So you have saccadic intrusions that time. Now, two important things is that saccades are normally present for normal physiological like in the optokinetic nystagmus, you have the slow phase, which is following a particular thing, and then you have a fast phase, that is a saccade. So that is physiological. Also, for a pathological, in a pathology like nystagmus, once you have the slow phase and you have a corrective fast phase, which is a saccade. Now, what is adaptive control? Adaptive control is the adaptation to a certain environmental change or certain defects. So I call the cerebellum a corrector. So what does it correct? So you have the vestibular ocular reflex, which will correct the based on the head movements, how the eye movement should be. The cerebellum will correct that if anything is required to be corrected. Second is to maintain the gaze. If I look to the right, like along with the neural integrator, which is the brainstem, the cerebellum also helps to maintain the gaze. Third is smooth movements to make sure that I have a smooth saccade, I have a smooth pursuit. The saccade is not overshooting or undershooting. To make sure all this is there, I require a cerebellum. So the cerebellum is the vestibular cerebellum is comprised of flocculus, paraflocculus, nodulus, and uvula. Then for maintaining that accuracy of movements, the saccades and the pursuits, and also making sure there's no undershooting or overshooting, we have the oculomotor and the vestigial. So which system is to be blamed? So we can use eye movement recordings. We look at the slow phase. And based on the slow phase, if it is linear, we say that it is vestibular nystagmus. If it is increasing, we'll say it's congenital. And if it is decreasing, as in this, then it is gaze evoked or involvement of the neural integrator. And if it is only the slow phase, like a pendular waveform which you see, it is pendular nystagmus. Okay, now we learned some basics about about the slow movement systems. Now about the clinical history. So the clinical profile, most of the time when the patient comes to you, they don't complain of any nystagmus. Okay, so they don't usually complain of shaky movements. So they just usually they're asymptomatic. We just examine, suddenly pick up some nystagmus. And then for me, I get referrals. Somebody finds out some nystagmus, they call me, this patient has nystagmus, come and see the patient. So most of the time, patient is asymptomatic. So at times, what happens is they may complain of obstruction. They say that whatever they look, everything is looking shaky. The shaky pattern is more towards the fast phase. At times, very rarely, they might be complaining of decreased visual acuity. That usually they don't come to us. It is seen in congenital nystagmus when they have a sensory component. Then, if in the emergencies they come with complaints of they have vertiginous sensation. So when they come of acute vertigo, then it's your job to see whether it is a vestibular component where you can give it to ENT, or is it like a one central cause of nystagmus and vertigo, where you have to do imaging and do further. So the vestibular component will be having more of nausea, vomiting, hearing loss, tinnitus. The brainstem symptoms, they'll be having long track signs with weakness, sensory symptoms, with ataxia, along with cranial nerve involvement. And always all patients with nystagmus look for history of drugs. Most of the patients, they might be on some sedatives or they might be on anticonvulsants, which can cause nystagmus. And also ask for family history. Like if they have spinocerebellar ataxias, they might be having a familial history of that. And the nystagmus is just one of the signs which they have. And social history of alcohol and drugs. Alcohol is causes cerebral toxicity. Even alcohol can also cause similar complaints. So when you examine a patient, you always start with the primary position, and the primary position look for any spontaneous nystagmus occurring. If there is no spontaneous nystagmus, then you start looking at all directions of gaze. Then you characterize how is the nystagmus. Is it like a pendular type, with which you can only see the slow phase, okay, with equal velocity, or is it like a jerk type? Jerk type with a slow phase and then a fast phase. Then also see how is the amplitude of the nystagmus, what is the frequency of nystagmus, any null point, any particular position where the frequency and the amplitude reduces. At times, you need to examine the patient for some more time. Like in the spontaneous phase position itself, you look for some time and see for any change in direction of the nystagmus, which can happen in periodic alternating nystagmus. And then if it's long-standing, they might be having some compensation, like a head tilt and head turn. And also, don't forget to examine for saccades and pursuits, which suggest you have a central cause of nystagmus, and also do a vestibular ocular reflex. Now, vestibular nystagmus, it not just be peripheral, it also can be central. The peripheral is involvement of labyrinthine, the vestibular nerve roots, and the root entry. So they'll if it's a peripheral cause, they'll have like a horizontal rotating nystagmus with a linear slow phase, and it is always unidirectional. It's always the same direction. And then, so it's the fast phase, usually the direction of the opposite to the direction of the diseased ear, and the patient usually fall to the side of the diseased ear. There's also Alexander's law, which says that the amplitude of the fast phase the amplitude always increases in the direction of the fast phase. These patients complain the complaints of vertigo, and depending on the duration of vertigo, they can be very short lasting, like a BPPV, or it can last for days, as in the case of labyrinthitis. So in peripheral, the most important thing is it's a jerky nystagmus. Okay, first. Second is it is unidirectional. And third is that it can be horizontal or horizontal plus torsional. The central causes, it is usually, if it is pure torsional, or it is pendular in primary gaze, or if it is direction changing, or if it is asymmetric, then you consider it being a central cause of nystagmus. Now, one characteristic feature of peripheral nystagmus is that it diminishes or dampens on fixation. So one way to bring it out is to doing some enhancing maneuvers. So we can use the ophthalmoscope with covering one eye to look at the optic disc, and you can see the movement of the fast phase of the optic disc. Second thing is that you can do is the use of Frenzel's goggles. So this is a highly magnifying glasses with which your the fixation can be abolished. So you can also see the nystagmus better with the Frenzel's glasses. So this is a 40-year-old gentleman with sudden onset nausea and vomiting. You can see the fast phase which is beating to the right side in primary gaze, and looking again, and it's beating the right side, and when you're looking to the right side, again right beating on left, looking to the left side. Again, it's right beating on up gaze and down gaze. So all directions of gaze, it is right beating. So it's unidirectional. Second is that I'm going to ask him to fixate. On fixation, there's dampening of the nystagmus. So all these rules suggest to offer peripheral cause of nystagmus, peripheral vestibular nystagmus. Okay, now we'll talk about the mechanism of this. So why does this happen? So basically, this is you're tilting your head. I'm tilting my head to the left side. So if I'm tilting my head to the left side, what happens is when my left semicircular, this is angular rotation, tilting my head to the left side. So I need to look at this one particular thing. So what happens is my right semicircular canal is activated. My right semicircular canal is telling my eyes, that is my left side lateral rectus and my right middle rectus, to look to this side. Okay, so as a result, my eyes will look to the opposite side. Now in primary position, normally the both semicircular canal have like equal firing and it cancels out. But imagine if the left semicircular canal is not functioning. So what happens is the right semicircular canal becomes overactive. Okay, so because of this, you have the slow phase towards the left side. And then you have the correction, which from the frontal lobe. It's saying, don't look there. Go back to the primary position. So that is the correction phase, which is a fast phase. So the slow phase is going to the diseased ear. And then there's a corrective fast phase, which is going to the opposite side. Is that clear? So that is vestibular nystagmus. Now, BPPV, why am I bringing this? It's a correctable cause. Okay, most of the time they'll come to the emergency saying that I have vertigo. So emergency team will call you. They will like, come, this patient has vertigo. Go examine the patient. You examine the patient. We're not able to get nystagmus in primary position. He's coming at vertigo. He's saying that I have episodic vertigo, and this episodes I'm getting when I'm lying down, when I'm tilting my head to the right side. Then you're like, okay, fine. So then you examine. You need some signs, no? So you examine. You look for nystagmus, is not there. So then you'll think, okay, maybe you need to do some maneuvers to bring out the nystagmus. So this is one of those conditions. Second is a very treatable condition. So what is the cause of this? It's mainly one otolith which goes to the posterior semicircular canal, and because of which it causes increased function of the semicircular canal. So it can be idiopathic, or it can be viral infection, or secondary to head trauma. So this is a maneuver which you do. It's known as Dix-Hallpike maneuver. So this is a right, he's got right BPPV. You tilt the head to 45 degrees, and then you look for nystagmus. So you can see there's a torsional, there's an anticlockwise, torsional, and upbeating nystagmus. So the feature about that is it is fatigable. That means that it slowly, gradually dampens on its own. The amplitude and frequency both dampens. It's very short lasting. And at times there might be a period where it takes some time to start. That is known as latency. Okay, so compared to the central cause of nystagmus, in central cause, you don't have latency. The duration is longer, and then there is no fatigability. So this is a treatable cause of BPPV, right? So there's one maneuver you can do, like you can further do some certain positions. It's called as Epley's maneuver. That is basically to take off to dislodge that otolith from the posterior semicircular canal back to the saccule. So that is known as the Epley's maneuver. So you do certain positions to make sure that it comes out, and following this positioning, he's completely well. Now look at this patient. So what is this? He's got so we're looking, I'm asking him to, I'm looking at his gaze. I'm asking him to look to the left side. What happens? What do you see when he looks to the left? What is the fast phase? Left side. Now again, look at the fast phase in the right. Which side is it? Right side. So it is beating each direction of gaze, it's beating more in that direction. Correct. So it's a gaze evoked nystagmus. So I'm asking you to look at the right, the fast face towards the right. Asking you to look to the left, the fast face towards the left side. So this is a gaze evoked nystagmus. Okay, so nothing in the primary position. Only when I'm looking at the either gaze, I'm getting it. Okay. So my question is now, he doesn't have any symptoms. He is coming, I've given some medicines, and then mainly he had some different complaint. He had epilepsy. And for that, I've given him some phenytoin, and then he comes to me with this. And he doesn't come, I just examined routinely. He's saying he doesn't have any epilepsy, so he doesn't have any further seizures. He's good with that. But then I examine him, he's got this nystagmus. So the most common cause, one of the most common causes is that it's because of drugs. Okay. So not all gaze evoked nystagmus is pathological. There's also physiological nystagmus, okay, which is again gaze evoked, and it's up to a particular 30 degrees. So once up to 30 degrees, you'll be having the nystagmus, which is fatigable. Sometimes it can become sustained if it is more than that, like more than 40 degrees, that is like more of an eccentric gaze. It can be, again, it can be sustained. You'll have a sustained gaze evoked nystagmus, but this one is very low amplitude, less than 4 degrees. So when it comes to pathological, if it is a very larger amplitude, more than 4 degrees, or if it is a exponential slow phase, especially when it's less than 40 degrees, or if it is asymmetric, you think of pathological cause of nystagmus, pathological cause of gaze evoked nystagmus. And this is because of the involvement of the neural integrator. So I've told you before, the neural integrator is to make sure that you have maintained the gaze. To maintain the gaze is the neural integrator. Something is wrong with the neural integrator. That is why you have the gaze evoked nystagmus. So it can be because of medications like sedatives, anticonvulsants, or it can be because of drugs or alcohol, or because of structural lesions. So coming to central cause of nystagmus, it can be jerk nystagmus or pendular nystagmus. I'll be talking about nystagmus, which is of localizing types. Just look at this image. So this I'm going to talk about mainly the gaze evoked nystagmus first. So in primary position, there is no nystagmus. So I'm looking, when the patient looks to the right side, just see the frequency and the amplitude of the nystagmus. So you can see the fast phase, and then, so the fast phase is towards the right side. That's very clear. You can see there's a high frequency and low amplitude. It's very fine nystagmus. Can you see that? Okay. Now it'll look to the left side. So you can see there's that frequency has reduced and there's more amplitude in that. Okay. So basically the first time when you look to the right side, what happens is you have a higher frequency, and there is a lower amplitude. It's very fine nystagmus. And it started looking to the left side, again gaze evoked. When you look to the left side, again the amplitude is more larger, and it's like more coarse nystagmus, and it is a less frequency, like less frequent. So there are two different types of gaze evoked nystagmus going on. That's very clear, right? So when he looks to the right side, what is happening is it is because of the vestibular component of the opposite side. So I told you, if the lesion, if your opposite side is involved, you'll have fast phase to the opposite side, correct? So that in the right side, what you have is something is wrong in the left vestibule, which is causing that symptom in the right side. And the left side, what is happening is there's something wrong in the neural integrator, which is causing the symptoms in the left side. So she's got some lesion on the left side is what we are saying. So this is an acquired nystagmus, a localizing type in the CP angle. It's called Brunn's nystagmus. So it has a gaze evoked contralateral high frequency, low amplitude. There's a vestibular component, and ipsilateral low frequency, high amplitude, which is a neural integrator from the brainstem. And this is because of this is mainly localizing to a CP angle. This patient has got a left side large CP angle tumor. Now look at this patient. Again, it's in primary position. This is primary position. There is no nystagmus. As she looks to the right side, she'll have a right beating gaze evoked nystagmus. And then as she looks to again comes back to the primary position, she'll have a left beating nystagmus. Okay. She has initial right beating, then comes back for primary position, it becomes left beating. So there's a change in direction of nystagmus. So that is known as a rebound nystagmus. Okay, and that is localization is to the cerebral disease. Now this we already covered in the previous, it's already covered before. So this is got a lesion in the brain. Okay, I'll show you the video. In the right eye, she is not able to adduct. and she's got left eye, she's got nystagmus. Can you tell me what this is? Yes. So she's got a INO because of involvement of the right MLF. There's a deficient weight in imaging. So right MLF involvement is causing the right INO. So the abducted nystagmus in left eye, this is called a dissociated nystagmus. The abducted nystagmus in the left eye is because of it's like adaptive mechanism to compensate for the contralateral adduction weakness. Now look at this video. So it's beating towards the right side. And then there is a period where it stops, gradually comes down, reduces, dampens. So you can see that. And now it will start beating to the opposite side, to the left side. It will become faster and faster and faster. Can you see that? So initially it was beating to right side, then it stops gradually and it starts beating to the left side. So this is known as periodic alternating nystagmus. Okay, this changing direction every 90 seconds. So this localization is the cerebellum, the nodulus uvula, or is because of cerebellum medullary junction. The etiology based on how the temporal profile is. If it is acute, subacute, you think of medication, strokes, paraneoplastic. If it is chronic, you can think of degenerative or structural causes. So it's a spontaneous nystagmus. The important thing is this: if you have a spontaneous horizontal nystagmus, in the absence of acute vertigo, the direction should be checked for at least 90 seconds. Look at this video. She's got a slow phase up and a fast phase down. Can you see that? There's a vertical nystagmus, so the slow phase up and fast phase down. So there's a downbeating nystagmus. This is acquired nystagmus. Its localization is to the cerebellar flocculus or paraflocculus or CV junction. Similar to the previous etiology, it can be because of acute, subacute like medications, infections, inflammatory, or chronic because of structural degenerative causes. The mechanism of downbeat nystagmus is because of the overactivity of anterior semicircular canal, and this causes activation of the inferior oblique and superior rectus, or contralateral inferior oblique and superior rectus, and this causes the eyes to slowly move upwards, and then you have the correctus saccars downwards. So this is mainly because the flocculus or the cerebellum, that inhibition is lost, which is normally that flocculus or cerebellum inhibits the anterior semicircular canal so that this doesn't happen. So the flocculus, if it gets involved, this can happen. So the localization is at the level of cerebellum. So this is another nystagmus. You can see this is the opposite of that. This is a upbeating nystagmus. So there's a downward slow phase followed by upward fast phase. It is not as localizing as a downbeat nystagmus. It's either to the cerebellum, midbrain, or medulla. Etiology can be stroke, demyelination, Wernicke's encephalopathy. So mechanism of upbeat nystagmus is involved is the overactivity of the posterior semicircular canal, which causes activation of inferior rectus and superior oblique, and the eyes will go down, and then you have the correctus saccars up. Look at this. So here I want you to look at the scleral vessels. Is it clear? The scleral vessels here. Just look at that. Can you see that? Can you see it? So what is that? What is that? It's a torsional type. And is it clockwise or anti-clockwise? It's clockwise. Okay, so important thing is that one important is that if you have a torsional nystagmus in primary gaze, one important cause is a central causal nystagmus. Okay, so central cause, most common cause is because of a medullary lesion. And these medullary lesions, usually you have an ocular tilt reaction. They have they have a skew and they have a tilt of the head also. So pendular nystagmus, usually it has only slow phase, there's no fast phase. It can be horizontal or vertical, or it could be dissociated, or it could be congenital or acquired causes. So this is a child and just try to see the slow phase and the fast phase. So you can in this video you'll be seeing a jerk, and along with that you'll be seeing some pendular movements, the slow phase. The jerk is towards the right side, along with that slow phase which you'll be seeing. So there's a mixed nystagmus which is happening in congenital nystagmus. So the child will be having both a horizontal pendular waveform along with the jerk, which is there in both primary position as well as the end gaze. It's usually seen at 2 to 4 months. That is the time for fixation. They'll be having no oscillopsia. There's no complaints of any shaky vision, and they might be having some places where they might be having where the nystagmus reduces, like called a null point. And they might be having some head oscillations also. There can be two types. The congenital sensory nystagmus are the one where the visual acuity can reduce. So they'll complain of reduced visual acuity. The congenital motor nystagmus, they don't have any, they'll only have this nystagmus. So they don't have any visual symptoms. This is a type of congenital nystagmus. So in primary gaze, I mean, if you look without, I mean, normally he doesn't have any nystagmus, but you cover one eye, what you see is that you'll start seeing jerky movements in the right eye, which is away from, which is fast component, which is towards the uncovered eye. And you cover the right eye. Okay, this is known as latent nystagmus. It is benign condition. Now, there's a condition, I think it's a spotter. You can tell what it is. So there's again, there's a pendular nystagmus, horizontal pendular nystagmus, very asymmetric, more on the left side. It's very shimmering movements, very high frequency shimmering movements in the left eye. Along with that, she's got ocular bobbing and tilt of the head. Can you tell what it is? Yeah. So this usually benign, usually resolved by 5 years. And you should, when you can divide congenital nystagmus from spasmus nutans, basically the waveform is only pendular compared to the mixed in which you're getting congenital nystagmus. It is asymmetric compared to symmetric, which is getting congenital nystagmus. It's a very high frequency, and patient will have that part of the triad, that is head bobbing, the tilt, the torticollis. Usually it's benign, but rule out any supracellular mass. Onset is later as compared to the congenital nystagmus, 4 to 14 months, and usually resolves by 5 years. There's a child with a monocular nystagmus, visual deprivation. He's got a horizontal nystagmus in the right eye. So I mean, like you should always roll out get a MRI for this patient to look for any chiasmal gliomas. There's an acquired form of glioma of nystagmus, of pendular nystagmus. There's a 25-year-old lady with hypercoagulable state. She's got a brainstem infarct and diplopia 10 months back, and after that she started developing oscillopsia. So you can see this. It's a vertical pendular nystagmus. For the examination, she was found to have this parietal tremors. Can you see that? She's also got some tremors in the eyes also. So it occurs 10 months after infarction. It's mainly involvement of the Mollaret triangle over here. In the involvement, so if there's infarct in this area along with the central terminal tract, it causes like this inhibition to the inferior alveolar nucleus is lost. So you have overactivity of this. So then what happens is you'll have all this hypokinetic movements, which is also present in sleep. So these patients will have a pathology in the inferior alveolar nucleus. You have a hypertrophy of the inferior alveolar nucleus. This is again our spotter. So you can see this convergence nystagmus along with this periorbital movements. What could this be? So this is a convergence nystagmus. It's a oculomasticary myoarrhythmia. It's a pathognomic for CNS Whipple's disease. This is one more. So this patient actually complains of headache with visual symptoms, and you can see these eye movements. So it's like one is going up, one is coming down. Can you see that? Let's keep on doing that. So that's the intorsion elevation of one eye with a depression extorsion of the other eye, and then followed by it's just reverses. It's a seesaw nystagmus. And all of this patient is found to have a paracellular mass. So it is mainly is maybe due to the loss of the crossing chiasmatic fibers, and always look for any paracellular midbrain lesions for such patients. This one video of convergence retraction nystagmus. So I'm asking the patient to look up, and suddenly the eyes converge, and also the eyelids, if you can see eyelids also retract. The eyelid retraction is known as Collier's sign. Okay, and this because of this excessive convergence tone, this patient has got a dorsal midbrain lesion. So along with that is part of the Perinaut syndrome. So they'll also have a pupil light near dissociation and upgaze palsies. This is the last part. So this you can see this video. So can you just characterize what this is? It's only the fast phase, which you can see. There's no slow phase, and there is it's just it's like saccades, back-to-back saccades with some intersaccadic interval in between that. This is called as square wave jerks. So the square wave jerks basically is back-to-back saccades with the intersaccadic interval is called as a square wave jerks. If its amplitude is bigger, it's called as a macro square wave jerks. If you have a crescendo decrescendo, especially at the time of fixation, it's called as a macrosaccadic oscillations. If there is no intersaccadic interval and it's happening only in the horizontal in the horizontal direction, it's called as an ocular flutter. And this is because of the dysfunction of the omnipause neurons. So this there are two videos. So this, can you see this video? This happening, ocular flutter is happening only in the horizontal direction. There is saccadic with, the back-to-back saccades without any intersaccadic interval. If you see this patient, he's having the movements in all directions of gaze. This is known as opsoclonus. It's happening horizontally, vertically, and oblique. So in this patient, look for any underlying paraneoplastic conditions, any encephalitis. The last one. You can see there's a fast component. It's like it's going down, and then the slow component. So it usually in in pendular nystagmus, you have the slow phase and then the fast phase. Here you have the fast phase, then the slow phase. Second is asymmetric. This is known as ocular bobbing. And this is seen in pontine lesions. So such patients might be having a locked-in syndrome, and then they might be having some horizontal gaze paralysis also. So after the last thing, so approach nystagmus, is there a slow phase? If there's a slow phase, is nystagmus? Is it a jerky type of nystagmus, or is it a pendular nystagmus? Then if there is no slow phase, then it's a saccadic abnormality. If the intersaccadic interval is present, square wave jerks, macrosaccadic wave jerks, or macrosaccadic oscillations. Or if there is no intersaccadic interval, it can either be opsoclonus or ocular flutter. These are the nystagmus localizing values. So if you have downbeat and periodic alternate nystagmus of cervical medullary junction or cerebral nodulus, upbeat nystagmus cerebellum medulla midbrain, convergence retraction nystagmus dorsal midbrain, CS1 nystagmus paracellular midbrain, and oculopalatal tremors, central tegumental tagmoloidal triangle. Ocular mastocytic myarrhythmia is Whipple's disease. Rebound nystagmus is cerebellum. Spasmus nutans, you think of excluder chiasmal glioma, it is usually benign. Presence nystagmus, cerebellar pontine angle. These are my references. Thank you.